that have been with us this year, and then they're moving on to other venues. Michael McCurry is going to do interventional radiology, I believe. Is that right, Michael? And then Rebecca Keller is going to do urology. Okay, so we've enjoyed having them for the year, and they get their chance to shine here this morning, Grandrounds. Look forward to it.
Thank you. Thank you, Dr. Burns and Dr. Giles, for letting me spend my preliminary year here. It has been fantastic, though I will say I am looking forward to radiology. So in that setting, I'm going to talk about blunt abdominal trauma and angioembolization, which blunt abdominal trauma you could have a whole year-long case series on probably. So I will try my best to get to everything within 30 minutes. So I have no disclosures. And then I'm going to do something a little different than an interesting patient. It'll be sort of a mini case series going over the three main abdominal and pelvic trauma cases that we see. So it'll be splenic, pelvic, hepatic, a short case of each, and then we'll go through some updated guidelines and algorithms based on those cases. So the first case is a 58-year-old male, moped versus tree, who initially presented to an outside hospital actually 24 hours after initial injury because he passed out when he stood up. He was relatively healthy beforehand, and he actually had a CT scan obtained at an outside hospital, which we will go through. But when he arrived at our trauma bay, he was relatively hemodynamically stable, slightly tachycardic to 103, and his abdominal exam was remarkable for tenderness over the left hemiabdomen without rebound or guarding. His laboratory workup is seen here, and then we'll go through his CT briefly. So as we scroll down, you can see a small hiatal hernia, which was not traumatic. And then as we get to the spleen, you can see areas of extravasation within old areas of hematoma. He also has some free fluid around his liver. He has a perisplenic hematoma. So we'll keep scrolling down. I've sort of limited it just due to the size of the PowerPoint. So he was, based on his CT findings, determined to be a grade 4 spleen, which we'll go through the grading classification here in a second. With active extravasation, and so he was referred to angiography. So this is selective angiography of the splenic artery, and you can see little foci of contrast extravasation here. And then this is just advancement of the catheter a little further, and you can see better representation of extravasation. There also is not great parenchymal uptake here, which is indicative of a contusion. And so then a microcatheter was advanced out further into the distal splenic artery segmental branch, and then he underwent coil embolization, which you can see the coils here, and then this is the post-angiographic or post-coiling angiography run. So the double AST splenic injury grading scale is probably something definitely all radiologists should know, and probably all surgeons should know. And the easiest way to remember 1 through 3, for me at least, is grade 1, a laceration is less than 1 centimeter. Grade 2 is about 2, so 1 to 3 centimeters. And then grade 3 is greater than 3 centimeters in depth. And then you have hematoma, subcapsular hematoma classification, so it's less than 10, 10 to 50, and greater than 50. Grade 4, which is what our patient had a confined active parenchymal bleed here, and then grade 5 is a shattered spleen. And so the theme for this talk will be looking at the West and the East guidelines for splenic, hepatic, and pelvic trauma. So I'll try to break down each of them as best as I can. They're not all from the same year. Some of them are older than others, and some West I thought were more inclusive than some East, and vice versa. So I'll try to hit the high points because there's a lot of information throughout all of them. So with any trauma, especially with blunt abdominal injury or penetrating, is whether or not the patient's stable or unstable is your first decision. So in the setting of hemodynamic instability, with or without peritonitis, you would have operative versus non-operative. Obviously, in that case, operative would be indicated. And then non-operative, which once you get past this first branch point, this is where the meat of these recommendations go, is observation alone versus embolization. And so it's based on CT grading, and their recommendations suggest that grades 1 and 2 observation, even with a very small foci of contrast extravasation, is the acceptable care of management initially. Grade 3 is where it gets a little more cloudy. So if you have no contrast blush, it's sort of equivocal whether or not the patient would benefit from angiography. Grade 3 with blush, it's agreed upon that angiography should be considered in these patients. And then grade 4, in a non-operative stable patient, angiography with or without then embolization is indicated. So they broke down, looking at the Form 5, this was probably 6 pages worth of the paper summarized into this table. But you see grade 3 splenic injuries here, and then grade 4 listed here. And you see the percent that underwent non-operative management for each category, the failure of that non-operative management, and then the percent of those who underwent non-operative management, those who underwent splenic artery embolization. And so I'm going to highlight these 3 studies here because you can see that all of them underwent splenic artery embolization. And so these centers were a part of a larger study that they mandated referral to angiography. Just because they mandated a referral doesn't mean they actually went. That is sort of a caveat with that. But you can see in these 2 studies, the failure of non-operative management is significantly lower than these. Obviously, there's a 64% glaring at you in this study. And so from the Wake Forest study, which was, you can see 8% failure, I sort of looked into this one a little closer. You can see one of our previous graduates, Dr. Hildreth, there. So again, all of the patients were referred to angiography, and essentially they looked at a predetermined date, and before that was the early group, and then after that, mandatory referral was the late group. The early group, there were 153 patients with grade 3 through 4 injury, and 80, so about half, underwent non-operative management with a small overall percentage, 21 out of 153, or 21 out of 80 in the non-operative arm underwent angiography, and then an even smaller percentage undergoing embolization. And then after the mandatory referral, you can see that those who underwent angiography went up significantly, as you would expect. So 106 out of 113 underwent angiography. Those 7 were, again, left up to the discretion of the angiographer, so that was why not all 113 were there. And then there were a few patients who had acute renal failure that negated their ability to receive a large contrast load with embolization and angiography. So when you compare the 2 groups, you see the failure rate in grade 3 is 14% in the early versus 3 in the late. And then grade 4, you have a failure rate of 17% versus 7 in the late. And then early, grade 5 is sort of, it should probably be tossed out altogether just because the N is so low, and it's 100% failure rate in the early and then 50% in the late. And so then I wanted to come back to this one because I don't think you can just ignore it. And so you see this little asterisk, and in this study, only patients with the contrast blush were included. And so granted, it's one study and it's tough to base a whole set of guidelines off of one study, but it at least made me question if you have a grade 4 or 5 injury and active extravasation with this high of a failure rate, should you just bypass the angio suite altogether and go straight to the operating room for definitive management? And so briefly, distal versus proximal embolization, so that when you read the radiologist report, you can understand what exactly they were doing and or hoping to accomplish. So proximal, you decrease overall blood flow without causing overt infarction, whereas distal, you're going to have a higher rate of focal splenic infarction. Proximal is preferred when there's no blush identified, which makes sense if you don't have something to aim for. You'll sort of more globally embolize, whereas distal is more appropriate when there is a specific foci of extravasation. Proximal, you have a lower rate of infarction as well as abscess formation and theoretically better immune function post-embolization because you have a higher rate of preserved blood flow to the spleen based on collaterals, which I'll briefly go over as well. But when comparing the two, there has been no great randomized trial showing one to be superior to the other. And both, if you undergo both procedures or either procedure, both groups need to have re-imaging within 48 to 72 hours to rule out pseudoaneurysm development. So briefly on the anatomy, from, I guess, more of an interventionalist point of view than a surgeon point of view, though I'm not claiming to be an interventionalist at all. You have celiac axis seen here, giving rise to the common hepatic, the left gastric, and the splenic. And then we'll go through a few slides where I'd ask you to pay close attention to the branches coming off the splenic, which you have the left gastroepiploic joining the right gastroepiploic. And then you have pancreatic branches coming this way. And then the short gastrics are not depicted here or labeled here, but you have those as well. So when you do a proximal splenic artery embolization, the collateral blood flow, I'd always struggle to visualize this. I thought this was a good representation of this. You can see the depiction of the coil here, and then you have collateral flow going through the left gastric into the short gastrics and then reaching the spleen. Another route of collateral flow is the common hepatic into the GDA, going into the right gastroepiploic, into the left gastroepiploic, and then reaching the spleen. And then the one that I always have to look at a little more closely is the pancreatic branches. So the ideal location for your coil in this case is in between your dorsal pancreatic artery and your great pancreatic artery. So this is your dorsal pancreatic artery feeding a transverse pancreatic artery. And when you have a coil here, blood flow will be reversed through the transverse pancreatic artery and then up the great pancreatic artery into the spleen. So I know that's a lot of pictures very closely together. And then the East guidelines for splenic trauma I thought were a little more hodgepodge and not as well put together, in my opinion, for whatever it's worth, compared to the West. But one thing remained true throughout all studies is that a level 1 recommendation, which is based off class 1 data, which is randomized prospective data, is that patients with diffuse peritonitis or hemodynamic instability after blunt abdominal trauma should be taken for laparotomy. And then there were quite a few level 2 and level 3, and I don't think I have enough time to go through all the level 2s and 3s for each East study, but I'll point out number 3 first, is that hemodynamically stable patients without peritonitis and abdominal CT, which we usually always obtain with IV contrast, the caveat being that their renal function is okay, should be performed, as that's the gold standard in diagnosis. And then number 4, angiography should be considered in patients with injuries above grade 3 with the presence of a contrast blush, which they did not comment on the size of it, as like the West trial did, moderate hemiperitoneum, or evidence of ongoing splenic bleeding. And then level 3, much of these are going to be the same in the hepatic group as well, but essentially Reimaging level or number 1 states that reimaging should be based on clinical factors in terms of determining timing of reimaging. Contrast blush alone on CT is not an absolute indication for an operation or angiography. And then angiography is used as an adjunct for patients who it thought may be able to either delay bleeding or look for vascular abnormalities like pseudoaneurysm that you weren't able to definitively say yes or no on CT scan. So I'll try to go a little more quickly. I focused on splenic mostly because that's mainly who I feel like we refer the most cases to IR, but case 2 will be liver. So it's a 27-year-old previously healthy male who presented after MVC versus concrete wall. He had a right-sided needle decompression in the field for decreased breath sounds, and then eventually got a chest tube in the trauma bay. I'll highlight a complicated initial course, which I will sort of depict here in a second, but his initial vitals, again, mostly stable. He's not quite hypotensive yet with a systolic greater than 90, heart rate of 96. He did have chest wall tenderness, and his abdominal exam was non-distended, but he had right upper quadrant tenderness without rebound. So his lab values are also seen here. His hematocrit was stable on initial presentation. CT scan, you'll see multiple right-sided rib fractures, and then what was classified as a grade 4 liver due to 25 to 75% of a hepatic lobe involvement. But as we scroll down, you see large hematoma here. There's no area of active extravasation identified on this scan, but I'll point out that you can see his portal vein is intact. However, he has pretty significant compression of his hepatic veins and also moderate hemiperitoneum. And so this was his first scan. And then his second scan, repeated later, showed progression. This was then bumped to a grade 5 injury, and you can see how significantly compressed his hepatic vein is here. His initial course, he had a diagnostic laparoscopy on hospital day 3, which a large amount of clot was evacuated. And then he eventually had a HIDA scan on hospital day 10, which showed a large biloma, and then he eventually got a cholecystostomy tube placed. And then from that cholecystostomy tube, he had large hemophilia output. So he was then referred to, we had another CT scan obtained, which then showed pseudoaneurysm within the body of the liver. So then he was referred to IR. I thought this was an interesting series of angiography runs. So this is selective catheterization of the celiac, and you can see that there is no, the liver does not light up here. And so Dr. Calvert's dictation stated that this was a replaced right hepatic, which we'll get to, but I'm struggling to see the left hepatic coming from the left gastric, so it may even be a replaced common hepatic from the SMA. But you see here, sorry for the speed of the imaging, but you see coming from the SMA, right hepatic up to here, and then the next slide, you can see a pseudoaneurysm here that then has brisk uptake into the portal system concerning for a fistulous connection, which is then further highlighted. Well, this confirms the presence of the pseudoaneurysm was this run. So then he underwent coil embolization distal and proximal to the pseudoaneurysm with multiple Nestor coils. And you can see that the pseudoaneurysm is no longer detected and you don't have that fistulous connection. And then from a little more proximally, you can see that the pseudoaneurysm is no longer there and no longer fistulous connection. So liver injury grading scale, pretty similar to spleen. You have grade 1, less than 1, grade 2, 1 to 3, grade 3, greater than 3 centimeters in depth laceration. Pertinent to the liver, grade 4 is 25 to 75% hepatic lobe disruption or active bleeding extending into the peritoneum. And then grade 5 is a central vascular injury, so cava, hepatic vein, or greater than 75 hepatic lobe disruption would be grade 5 as well. And I briefly wanted to list this, excuse me. So this is the normal anatomy seen here with a replaced right hepatic. You have a type 3, which is seen in 8% of the population. And then this is a replaced common hepatic seen here. So West guidelines, I'll try to go through these quickly as well. Decision 1 is operative versus non-operative, just like splenic. If hemodynamically stable, CT remains the gold diagnostic standard. This paper was written mid-2000s, so there was a increasing use of the FAST exam, and in the presence of a positive FAST, as well as hemodynamic instability, it was indication for urgent laparotomy. However, the difference between liver and spleen is the success rates with non-operative management. So grades 1 and 2 in a hemodynamically stable patient, you have a 92% success rate. And then in the higher grades is where you see the major difference. So 3, 4, and 5 are 79, 73, and 63% respectively. So you may be able to get by a little better with observation in a stable patient compared to a splenic injury. There's no great consensus on which patients benefit from angiography like there was for splenic. But there was a brief mention of the location of a contrast blush. So if you have free extravasation with pooling into the peritoneal cavity, then 100% of those patients required operative intervention. If you had intraparenchymal extravasation, but with large hemoperitoneum, 2/3 of those patients eventually required operative intervention. And then intraparenchymal extravasation alone were able to be observed non-operatively, and all of those did fine. And then an interesting point that they also included in this paper is that bleeding from blunt hepatic injuries in the absence of other concomitant abdominal injuries may actually exacerbate the bleeding. And so I found this paper from Louisville that I thought did a very nice job of showing sort of trends in management. And so back in the 70s, selective hepatic artery ligation was much more frequently performed. You can see that 13% here, whereas even by the late 90s, that was being done less than 1%. And then you see increase in non-surgical treatment from 0 to 65%, and then increase in embolization with less than 1 to 9. Obviously, that goes hand in hand with increasing technology with angioembolization. The catheters and wires and embolic agents just weren't there in the 70s. And then another study, I thought to include this here at the end, was liver-related morbidities between those who received operative management and angioembolization were similar and actually even a little higher in angioembolization. So kind of summary is non-operative management, and then you really need to be selective on who you decide to take for angiography. Again, level 1 recommendation, hemodynamic instability or diffuse peritonitis with blunt abdominal trauma should go to the OR for laparotomy. And these are actually the exact same level 2 recommendations, just with liver substituted. So again, grade 3 number 3 angioembolization can be used as first line intervention for those who transiently respond to resuscitation. So those who are stable can be considered for angiography is essentially what that's saying. And then should be considered in a patient with active extrav on CT scan, and non-operative management should only be considered in an environment that is capable of monitoring. So essentially referral to a trauma center that can adequately take care of these patients. And then level 3, again, monitoring clinically should be your guiding light on when to reorder imaging. And then number 2 was sort of interesting to me. So interventional modalities, including ERCP, angiography, and other procedures, may be required as a result or as a way to manage complications that arise. So instead of a proactive procedure like splenic, it seems to be more of a reactive procedure due to complications, which makes sense because you have usually a high success rate of non-operative management. And then lastly, we'll get to pelvic. So this was a 84-year-old female who was relatively healthy, except for a past medical history of AFib on Eliquis, who was involved in an MVC. She was, on arrival, obviously very tachycardic to the 150s, but her pulse was irregularly irregular, and she was found to be in AFib with RVR that responded to IV metoprolol. Her abdominal exam was soft, non-distended. She did have some tenderness over the lower abdomen. And then her musculoskeletal exam, she had decreased range of motion proximally in the bilateral lower extremities, but maintained normal distal range of motion in her knee and ankle joints. And then she did have pain in her right anterior and left posterior pelvis with hip compression. She had elevated lactate as well as, based on old laboratory data from seeing providers in the Erlanger network, this was a stable HNH for her. And then she had a CT scan obtained, which we will go through here. So she had a lateral sacral ala fracture here, and then you'll see when we get down into the pelvis, areas of large hematoma, and then areas of active extravasation, as well as comminuted displaced parasymphyseal pelvic fractures. And so here's a redemonstration of the coronal view of her pelvic fracture with active extravasation within pelvic sidewall hematoma. So she was referred from the trauma bay to angiography. This is her initial run. She had a catheter placed in the distal aorta, and you can see small areas of active extravasation in her pelvis here. This was a selective run. It was actually in the internal iliac, but reflux into the external a little bit, so this is why you're seeing this vessel right here light up. But you see active extravasation better defined here, as well as some places here. Right here. So this is in the internal iliac, and you have anterior and posterior divisions. These were from the anterior division. Small vessels coming here, which in this location, the pelvic ring is right here. So this could be the obturator. I think it's a little LAO. Yes, sir. So, beating this horse to death, more extravasation, better defined here. And then she underwent coil embolization as well as gel foam. So she had coils placed across the active areas of blush, and then was further embolized with gel foam to sort of supplement that. Coils require an intact coagulation cascade in order to be effective, but if you do not have an intact coagulation Cascade, you can inject gel foam. You can reverse their INR if that's the cause, or give them platelets. But then you can also inject gel foam to sort of stick to the coil to help temporarily occlude the bleed. Then on the contralateral side, I skipped ahead through all those other runs. You see active extravasation here. This is down in the anterior division of the internal iliac. And so she also had more areas here. So she underwent just global embolization from the internal iliac with gel foam. And then this shows the adequate 3 beats of stasis post-embolization. So brief pelvic anatomy, obviously. You could spend a lot of time on this slide, but the way I break it down for the common anatomy is in terms of splitting anterior and posterior division is pill. So with posterior division, you have the iliolumbar, the lateral sacral, and the superior gluteal. And then much of the remainder on this slide is from the anterior division, excluding obviously the external iliac and femoral arteries, the internal or inferior epigastric, also not included. So Western guidelines for pelvic, this is the one where I thought the East did a better job of describing or laying out their recommendations. But the West guidelines, basically, as was the case with the rest of them, initial assessment is targeting hemodynamic stability. So 1A is if they're stable, you get a CT abdomen of the pelvis. If they're unstable, you give blood products, and then they mention massive transfusion protocol based on whatever your facility's protocols are, as well as TEG monitoring with placement of a pelvic binder. And then they provided the caveat, which is stated here. It's contraindicated in lateral compression fractures because the applied force actually worsens the deformity. So then they also recommend a FAST exam to sort of delineate whether or not you go to the operating room. So in the presence of a positive FAST and obvious pelvic trauma, you're better suited to go to the OR so you can do a simultaneous exploratory laparotomy and external fixation of the pelvis, or packing of the pelvis. If it's negative, you have an increasing number of options. Option 1 is pelvic stabilization with an X-fix in the ER, which is time intensive and according to this paper has fallen out of favor. Pre-peritoneal pelvic packing, which I'm not sure I had the opportunity to see. I've heard of a couple cases where patients have had that done here. And then option 3 is, we all know, is the REBOA, the resuscitative endovascular balloon occlusion of the aorta, and you, for pelvic trauma, would land it in zone 3, just above the bifurcation of the aorta. So with all 3 of these are temporizing measures, and this paper sort of touted angioembolization as being more of a definitive management option. And then the East, which I thought did a better job with pelvic, was a lengthy paper with a review of over 50 studies with this review committee of trauma surgeons, orthopedic surgeon, and an interventional radiologist that addressed 6 specific questions, which are listed here. So which patients with hemodynamically unstable pelvic fractures warrant early mechanical stabilization? Which patients require emergent angiography? What is the best test to exclude extrapelvic bleeding? Are there radiologic findings which predict hemorrhage? And what is the role of non-invasive temporary X-fix devices? And then what patients warrant preperitoneal packing? Numbers 1, 5, and 6 all had level 3 recommendations, and I have them in my notes, and they're in the PowerPoint, but I'm not going to go through them because there's so many. Numbers 2, 3, and 4 had more level 1 and 2 recommendations, so that's what I'm going to go through. So those with pelvic fractures and hemodynamic instability after non-pelvic sources are adequately ruled out are patients who should go for angiography, which is different than splenic and liver because you see hemodynamic instability, which in spleen and liver patients, they usually do not go for angiography. Those with pelvic contrast extravasation, regardless of hemodynamic status, require emergent angiography. And then I'm going to skip down here to patients greater than 60, which our patient was 84, with major fracture regardless of hemodynamic status. So she was hemodynamically stable and warranted, but suggestions they included here are with age greater than 60, they usually have pathologically worse fractures that could have delayed bleeding that's not necessarily identified immediately on CT scan, and then also increasing medical comorbidity. They're on more blood thinners, that sort of stuff. So, number 3, what's the best test to exclude intra-abdominal bleeding? So a fast exam is not sensitive enough to exclude the presence of intraperitoneal bleeding with a pelvic fracture. That's the main point of this. This, I think, took up about 3 pages of the article. But if you do identify, or if you do have a positive FAST, it has adequate specificity to recommend laparotomy, even in the presence of pelvic fracture, to control hemorrhage. And then this point, DPL is the best test to exclude intra-abdominal bleeding in the hemodynamically unstable patient. I'm not really sure why they included that, because they have a review like algorithm in the end where it's pretty much universally not undertaken. And then the last point, in the hemodynamically stable patient with a pelvic fracture, CT is recommended to better evaluate intra-abdominal bleeding regardless of FAST. So there's a little bit of contradictory information in here, I thought, but number 4, radiologic findings. So fracture pattern, presence of hematoma are important, and then CT of the pelvis is an excellent screening tool to exclude pelvic hemorrhage. Absence of contrast does not always exclude active hemorrhage, and then a pelvic hematoma of greater than 500 centimeters in size has an increased incidence of arterial injury. So I've briefly listed the types of pelvic fractures, which I will not go through. And then this is what I sort of wanted to get to. So we've already gone through this in not a diagram form, but these are listed on the Western Trauma website, and they're interactive. So each of these you can click and look at a patient's vitals, their scan, and show why they need to go. So I thought it was a great learning tool if anyone had any interest before they become trauma chief at looking at who would be a good referral candidate for embolization. This was blunt hepatic trauma, and then this was pelvic. Cost of medicine. This shows the cheapness of gel foam, and you can usually use 1 square, which is 12 square centimeters. So you can get out of there with $12. Coils are a little more expensive. If they're detachable, they're significantly more expensive. And these are some of the newer embolic agents, which are not used in trauma, but this is Onyx. It's a liquid agent. And then these are Embo spheres, which are used in hepatic embolization for HCC. So references, I'm sorry to Becca Keller for eating up way too much time, but thank you to this good group of people here.
Later next week, Dr. Greer's indicated that we could do that. Is that okay with you, Rebecca? Okay, good deal, because we don't want to cut you short on your opportunity to tell us about bladder injury. But there's a lot of things here that, we could discuss for a long time. Bob in particular, or anybody else that wants to comment, I guess one thing right at the end there, do we do DPL anymore? What is the,
Yes, we still do DPL. I think it's still useful in our patient population where you can't trust the reliability of a fast exam due to body habitus concerns. And we still have a DPL catheter in the trauma bay, and I think most of the faculty prefer to do open DPLs, and we have a set of Army Navies on the tool board down there so we can facilitate that. And you have unstable patient, you fast them, and you can't convince yourself that you're seeing fluid or not for whatever reason, we do an open DPL.
You wanna make comments, or?
Yeah, sure. Amazing whirlwind tour for such a junior person having such a commanding grasp, be able to work through all that material is a very nice job. It's like sitting here listening to the gospel. I think you nailed everything pretty succinctly. We do pretty much the Western trauma guidelines for splenic management. We have a new revised algorithm that's coming out in the latest edition of the Red Book, which will hopefully be ready for the new interns in July. It's has a few more branch chains in it. We look at risk factors for failure and non-operative management, which you highlighted, which is age greater than 55 is a big risk factor, and things such as portal hypertension and cirrhosis or other factors. But we rely, we're pretty much, if you're a stable grade 4, I think most people are winding up getting referred for an angio. Unstable grade 4 or 5 is going to the operating room. We are not routinely angioing grade 3s. We rely heavily on a repeat CT scan in 24 to 48 hours looking for evidence of progression, or in particular pseudoaneurysm formation in the spleen. It occurs much more frequently than it does in the liver, but that was a great case that you presented that did have a delayed pseudoaneurysm. As far as the livers go, that's if you got a blush, you get an angio. If you don't got a blush, then we manage most of those non-operatively and are aware of the complication of biloma formation. You can manage something completely non-operatively, and they get a biloma and have to have the GI place the stents up. The one caveat about angioembolization is you can infarct large segments of the liver and wind up having to go in and debride those. So that's another, problem that occurs in the vast spectrum of hepatic trauma. And I'll make one final comment about pelvic fracture and pelvic packing. It's only somebody like Gene Moore, who's like a major player in the trauma community, that can bring something forward like doing pelvic packing, stating that a hospital like Denver General doesn't have good enough angioembolization call-in times to rely on their radiology department to do that, so they pack everybody, which I think is a little more morbid than going to get an angio. But he has made that a national thing and states that you should do it, and don't call your interventional radiologists in. You don't need them. Go take them to the operating room and open up their retroperitoneal space and pack them. And I don't know that I feel that that is as secure as a way of just tamponading something externally as it is to putting coils in somebody's artery. I think that's a definitive treatment versus, something that's just really not as effective, at least theoretically in my mind.
I agree. It seems to me that the embolization, if you've got it available, is a much better way to go. Gene Moore usually demands evidence-based approach to things, so I'm surprised.
He's got some data for it, but
Yeah.
in
That doesn't make good sense to me.
the modern era, I just can't see.
Yeah,
It takes a
yeah.
real cowboy to push something like
Right,
that, and that's what he
exactly.
is.
Yeah, Dr. Greer?
That was a great talk. Yeah, if you've ever been in a pelvic hematoma, you don't want to be there. Proximal splenic embolization does not require vaccination, did you say?
It's facility dependent. I think there are more recommendations that you do not have to be vaccinated based on it. I'm not sure, honestly, off the top of my head, what our Red Book states, but
It's unknown as far as I'm aware. I think there's some people out there trying to collect antibody data on non-operative management, splenic trauma and embolization, and I don't think anybody really knows yet.
It probably wouldn't do any harm. What about any hybrid procedures where you get in a trauma case, you realize you need embolization, and you just do it on the table? I mean, vascular guys, we embolize things as well. I don't know if that's ever been done or talked about.
The East paper spent a large time talking about pelvic trauma and the need for hybrid ORs to adequately occlude bleeding with angioembolization as well as stabilize pelvic fractures, and that being one of the main roles. Obviously, I don't think your orthopedic surgeons will be embolizing much, but
But we do vascular. We do embolize a lot of
Right.
things similar to this, particularly aneurysm, type 2 endoleaks, and so forth. So that's available. It might be a course of action that could be considered. So
Mike, while you have what's the success, and Bob too, the success of coil or embolization of pseudoaneurysms, intrasplenic, hepatic? I mean, does that?
if you get a coil in the pseudoaneurysm, it's renal or splenic or wherever, they're very effective. I mean, those coils are not going anywhere, and they're going to clot. Rare for them to return, but
I agree completely. If you get a distal splenic artery embolization, I think the failure rate of that is like less than 2%.
What about splenic necrosis and abscess formation down the road after these things?
Ask that. It's been very low incidence of that until recently. We had some turkey show up on the ACS service with some splenic hematoma that no one knows how he got it, and high cardiac risk factors, and somebody had him coiled, and he infected his hematoma. We had to put a drain in it. He was just draining pus out of it, and we're still trying to put 10-foot pole marks on him, because he's a high operative risk. But that's in our experience, I think a pretty low complication.
Because the incidence of subphrenic abscess in multiple kinds of surgery on the left side it used to be something that we encountered, not regularly, but enough that you needed to know how to drain them. And splenic abscess is one of those, at least that I've been involved in a few times, and doing a posterior drainage and whatever on them. I just was curious how many of them, now that we're doing so much embolization, end up with necrosis down the road. They do have some pain, I know that, because we've had several. They have pretty significant pain for a while with splenic artery or splenic aneurysm embolization in patients that I've had. Has that been your?
yeah, pain and fever.
You get worried about whether you need to do something, or at least I did. I think other questions or comments. One, because I've got a couple of observations. Yeah, Dr. Moore.
Yeah, I thought it was very nice too. Do you have any data on, the pelvic embolization? It looked like you went after bilateral iliacs. Is there any data on any rectal ischemia that occurs after that?
there were a few reported small number of cases. I think there were 4 out of, I think that included 1,500 patients of gluteal necrosis, and then 1 or 2 with rectal ischemia from that with bilateral. Yes, sir. But pretty small, even still. You'd hate to be that one, though.
We had a gluteal necrosis here several years ago. I know, it's been 30 years ago, but we did. So I think one of the points I'd be sure to make try to think about your future and passing the boards. Oral board exam, eventually be ready to operate on these patients. Know what you're going to do. Because, I mean, this is embolization. I work with our interventional radiology colleagues. It's moved dramatically over the last 40, 50 years. But in an oral board question exam, you're going to eventually need to be able to operate. But you don't do it immediately. I mean, you need to work for that. This was a beautiful presentation of the sequential evaluation of the trauma patient. Unless, of course, they're hemodynamically unstable to start with, and then that's easy. You just go to surgery, right?
You need to.
But they don't give you that now.
They might if they want you to talk about how to operatively manage a liver trauma.
Well, now that could be too. I mean, occasionally you will have that.
Knowing how to do a Pringle maneuver,
Yes,
direct exposure, total hepatic isolation. There's 2 or 3 different techniques for operative management of liver trauma that you need to be able to discuss at least once.
Was to have somebody who never would go to surgery. I mean, you kept on having the interventional radiologist and give them more blood, and and it's amazing to hear for you guys that have done residency and have been around here long enough, I mean, you just don't do that. But there are obviously training programs in the country where you just keep on delaying going to surgery, and that's just not what you do.
And I have one final comment. This is
Oh,
my
yeah,
final
sure.
comment. After you made that comment is there's two types of grade 5 liver injuries. There's the greater than 75% contusion or hematoma, and then there is the hepatic vein injury where you see the blush coming right off the side of the vena cava. Trauma chiefs need to be able to recognize that and know that that's time to shoot the flare gun. That needs to go straight to the operating room. There is, in my opinion, for blunt trauma, there's no way to manage that injury non-operatively, and that cava needs some sutures in it, and that's the only way to treat that.
I think that is mentioning that point, though, about hepatic vein injuries, because that one of the first papers I was involved in years ago was how to approach that. Be sure you've got the patients prepped where you can do a thoracoabdominal incision, because you've got to do a thoracoabdominal incision to get control of that if you're going to control hepatic vein injury.
You got to get suprahepatic caval control. Sometimes you can peel the liver down off the diaphragm, or you can cut a hole in the diaphragm and get intrapericardial.
Get the whole liver out of there.
Or you can do a sternotomy and put the clamp on. However you think you're going to do it, but that's a...
Got to be able to mobilize the liver and get it up to get to it, take down the triangular ligament.
That's like the holy grail of trauma,
Yeah.
is fixing the grade
It's
5.
a tour de force. I've got some great slides if any of you want to put them in your file to use down the road of liver out here where you get to it, because that's the only way you can. But I think the compared to 45 years ago or so, we have learned to be far less aggressive, and you made that point. I think in the West criteria there about pelvic and hepatic hematomas and retrohepatic hematomas, we're not as aggressive. We've become less aggressive about the need for immediate surgery unless you have hemodynamic instability. Is that fair to say? Yeah. So, and interventional radiology has been one of the prime things that's helped us learn to do that, although non-operative management has too.
You made me think of one more thing. The little bullet you had about if they keep bleeding from a pelvic fracture, take them back to angio. We've had a number of patients that they've coiled one thing and 5 hours later something else starts bleeding, and so repeat angio for the pelvis, I think, is something everybody should keep in their mind.
Yeah, and that's secondary to collateral blood supply, and your slides were really great showing that both to the spleen, the liver, and the pelvis. Those are excellent slides there. Well, very good presentation, and Rebecca, we'll look forward to yours. I think we're going to try to do that next week. Thanks very much.
I was hoping we'd do the.
I guess we gotta log out, get mad.
Dang. Good job. You showed me up. Well, mine still looks so small. Mine's not nearly that.
Thank you. So, right at the beginning, she said, I'm going to try my and I laughed. But she said, I'm going to trauma that. And I was like, what a good fun.